Hi, I'm Dr. Vonda Wright, and this is Hot for Your Health. Join us for conversations on the bleeding edge of science, health, and culture as we bring you tech innovators, thought leaders, and the movers and shakers who are transforming science fiction into your new health reality. Hi, everybody. I'm Dr. Vonda Wright, and I'm so excited today to have you back on Hot for Your Health, where today it is World Menopause Day. And by the time this is released, we're going to be past it. But for 51% of the entire world, it's World Menopause Day because everyone born with ovaries is going to go through menopause. So it's very apropos that today I have Dr. Jessica Shepard. She is a nationally known OB-GYN who has focused on lifestyle, taken her practice from academia now into a private practice. Don't let me get that wrong. And on top of that, something I appreciate about what she's done is she just hasn't hoarded the information that she has. She has been all over the broadcast airways. She has shared her information with the public and has just released her new book, Generation M. So we're going to talk all about it today. But Dr. Shepard, thank you for taking the time. You've been all over the place lately.
It's been a whirlwind, but I think this is part of how we really need to amplify this message, is just taking every opportunity that we have. And so now that, no pun intended, that menopause is hot, I thought that it is very hot. And I think that that's great. We really need to use this as creating momentum so that women can continue to share the message and tell their family members and their friends so we can take away and strip that taboo.
In your practice as an OB-GYN, has your practice evolved in your career to focus mostly on menopause, or have you always been so open about it?
I think, just from classic training, when we think of OB-GYNs, we really don't get a great amount of menopause training. I even remember starting very early in my practice. You really only had like one tool. And then you always had to make sure, did you go 12 months without a cycle? That's, our traditional classic training. So over, the 15 years, I really started to focus more on the transition of perimenopause because it brought in so many other features. And there was kind of like all of these different other complaints. And it really intrigued me. And I find that about 7 years ago, I was like, I need to make a change and a shift in how I'm communicating with my patients, what I'm exposing them to. And I really brought that lifestyle part into it. And then I would say about 5 years ago is when I'm like, I really need to focus on hormones. I really need to kind of separate out my practice to just focus on midlife.
And so how does it work now? You live in Dallas. I know you do telehealth. A woman who actually is coming to me next week had just seen you on telehealth. Talk to us about our practice, because my women all over the world are always looking for good gynae doctors to talk through things. How does your practice work?
Yeah, so we have a brick and mortar. And again, this was when I left academics. I really wanted to change the kind of atmosphere which women walked into when they were coming in to talk about their health. And so we have a yoga studio in my practice. We have 2 licensed therapists. We have a registered dietitian. We have an esthetician, a massage therapist, a personal trainer, all in one building, because I wanted it to feel as if, one, women felt safe talking about their medical needs, but also creating a community where they said, you know what, because it's right here and I already feel comfortable, it's going to decrease those obstacles for me to come back and do the thing. Just like we were talking on our IG Live, is you can read as much as you want to, you can talk to as many people as you want to, but unless you're making those changes, you're not going to see that outcome.
So when a woman comes to you and if she says to you what she says to me is, I think I'm going crazy. I don't know what's going on. I don't even feel like myself. My clothes don't fit. The bad things.
Yeah.
What are some of the first steps that you encourage women to make to get themselves back or to re-recognize themselves?
The first thing that I usually start out with is, 1, you're not crazy, and 2, you're not alone. This is something that is experienced by so many other women. I think bringing into it the experiences of other women helps them feel reassured and connected. And then the other thing is really giving very simple definitions of perimenopause and or menopause so that they can see it from a perspective of not this heavy clinical diagnosis that sounds scary, and then inviting them into the conversation of, here are some things that we can do for it. Which ones for right now at this point that you're in your life, which ones seem appealing to you that you'd be willing to even start this journey? Because it's a marathon, not a sprint. And I want them to be able to kind of template it for themselves because I want them to be able to create their own journey. I should not be dictating how they go through this journey. I want them to be able to do it for themselves. So I give them foundation educationally and knowledge base, then allow them to insert themselves based on their own experiences.
How do you help people get to the point that they're ready for change? Because I've been doing this like you a very long time, and sometimes people think they're ready for change, but then as they see the work involved, the transformational lifestyle, I always say you can't out-excuse me.
Yeah.
I've heard that before. And so how do you get someone past their own gatekeeping?
Yeah, I actually like to write down their own statements. So for example, if they say, oh, I would like to start that, but ABC, I can't right now because of such and such. I'll be like, okay, so what I'm hearing is for right now, you can't do this because of this. I say, okay, what are some things that we can do to possibly still change the structure of what you're talking about? But also, I'm going to hold you accountable. So I do a lot of follow-ups. I tell them initially it's going to be hot and heavy where we're seeing a little bit more than where we might see each other down the road. And then when they come back, I'll say, where are we with this? Because this is what you said. I allow them to say, this is what I am interjecting into my own journey, whether it's an excuse or obstacle or whatever, so that they themselves can see it and saying, this was not put there by me, but I'm also willing to work with you towards getting this. So when there's more self-actualization and realization, but knowing that it's coming from a safe space of reassurance, a lot of times the change becomes easier because I'm not trying to persuade them and push them and maybe even shame them. And I think many women in society, even in medicine, have always been shamed when something comes up because they're not doing it the way that someone else wants them to do it.
Right. I think, I mean, I agree with you. I think that there are a lot of reasons women know what they should do and don't do it. And shame is one of them. Fear is another one. What do you think, besides fear of the unknown, some of the biggest fears that your patients experience to get on a path that'll make them feel better?
I think the biggest fear that I've seen or concern in my patients is HRT, getting on hormone replacement therapy. And again, we're just at the beginning stages of changing that narrative of the benefits of HRT versus the risk, which has been magnified over the last 20 years. And so I actually ask them, I say, well, what have you heard about it? Or what has your experience been in it? So then I can meet them where they are. Because many times if I just go in and say, oh, it's really good for you, it's not bad, it doesn't do this, I'm not necessarily addressing their individual concern. I'm just telling them what I know. So I always invite them to tell me, what do you know about it? Or where's your hesitation? Where's your concern? And then I can meet them where they are. And most times I would say probably in the high 80, 90th percentile, they'll be like, oh, well, either I didn't know that, or I really thought that this did this. And now we can open up that forum and that discussion. And it may not be in that visit that they choose to try HRT, but now the seed has been planted and they can make better decisions because I've given them the reason on why it can be beneficial for them and kind of taking that misinformation away out of the picture.
That's so interesting that you say that, because as I begin conversations, women will vehemently throw out, oh, I can't do that because my Aunt Martha's sister had breast cancer. And when I initially flashed back to say the data doesn't hold that up, It is so deeply inground since 2002, when the WHI came out. It's like changing a religion or changing the sky is blue, right? So this approach you're taking, it's probably much better than, I mean, that's not what I do now. I've been doing this a while, but how deeply ingrained that is in the think of the country is astounding sometimes, actually.
Yeah, because it's one of those, it was very sensationalized. It had a bad outcome, attached to it. And at the end of the day, when we think, and again, I always put into perspective, yes, I am very concerned about breast cancer and the risk that it may cause to you. I go, but can you tell me the number one thing that kills women? And so when we establish that it's heart disease,
Yes.
so in context, let's again step outside of it and let's look at that risk that you're so scared about, which really does have value. And I'm not diminishing it, but I also want you to talk about the things such as osteoporosis, heart disease, and dementia that also can impact you later in life. And how do you feel about that? And where does that now put its place into the category of lifespan and wellspan? They get to choose.
Well, it's as if you knew what I was going to ask you last, because I had the bookmark. I wanted you, because there's so much debate right now among different, I don't even know why people are arguing with each other, amongst clinicians, but clarify, again, people need to hear things a lot. I'll clarify osteoporosis. Estradiol is FDA approved for the prevention of osteoporosis in postmenopausal women, and I give it to everybody whose mother's shrinking, who's broken an arm, who is them at risk. But let's talk about heart disease.
Mm-hmm.
Can you just give us a few facts about the relationship between hot flashes and heart disease and the role of estrogen?
Yeah, the thing that I think is key about estrogen, and also, namely progesterone and testosterone, because I know I'm going to leave them out. But estrogen obviously is the quote unquote most popular hormone that women have. What we have done over the years is kind of stereo or typecast it rather to the pelvis. That people only think that estrogen is relevant in the pelvis, and it has to only do with ovaries and only has to do with your cycle and reproductive purposes. I like to always start with estrogen receptors are all over your body. They are in your brain, in your heart, in your muscle, in your bone, everywhere. Mm-hmm. And so when we think of hormones as, again, chemical messengers, and they're going to be the ones that are going to deliver the news to all these different organs, when we have a decline in estrogen, then that message is not getting sent. And the organ is therefore not going to function as well as it can because it's not getting the message. And so when we think specifically of heart disease, and when we look at the receptors that are on the actual cardiac muscle that respond to estrogen, whether it's contractile ability, whether it's the ability to decrease plaque formation in your vessels and the hardening, these are the things that, again, when we have a decline in estrogen, then you're going to start to see the aging process, which is going to be accelerated because of the decrease in estrogen. And so I always want people to understand the fundamentals of how everything is connected and what can really happen to you if you have a decrease in estrogen and how those organs in your brain and your heart and your bone respond. And so if we are starting to see from a statistic that has been proven over and over again for decades of heart disease being the number one killer of women, especially in the time frame after menopause, then we have to look at it from that perspective and saying, what can I do differently in addition to diet and exercise that's going to give me the best benefit for my heart to be the best heart that it can be? And a lot of that has to do with hormone replacement therapy.
So do we think that the role of estrogen in preventing, I'm just going to say that's one of the things that's controversial, but I'm going to say it, preventing the progression of cardiovascular disease and atherosclerosis, or hardening of the arteries in particular, does that have to do with the role of estrogen on inflammation within the vessels?
Yes. So generally in your whole body, if you actually look at, when we look at longevity markers and how estrogen has a direct correlation with inflammatory markers, and we really start to see kind of this change in the graph when you look at decline in estrogen and significant increase in inflammatory markers, that again is going to be directly impacted on how inflammation impacts these organs. And so specifically for the heart, when we think of atherosclerosis or the ability for the heart to its functionality and how well it can pump, yes, inflammation and estrogen are directly correlated. And so this is where it's hard to make, and this is why we're seeing all this controversy with these actual organizations, is because in medicine, we are always so evidence-based, but for good reason, to be sure. And so even though we can see in evidence that's been provided that inflammation causes, the atherosclerosis or the plaque forming, and we know that estrogen causes, or the decline causes, inflammation, in science, it's hard to explain to patients until we see a study that shows the direct correlation between those two things. It's very hard for us to make recommendations. That's where we are right now. And I think because we're so early in the menopause, I guess you can say, research era, causing what? Even when we talk about brain with Dr. Lisa Mosconi, and she's like, yes, we still are very much more conservative and slow in medicine to say, yes, we definitively can say this. We've done a study that is, X against X, and this was looked at this. We can't make those recommendations. But I do think as providers, from our clinical judgment and the ability to use the evidence that is currently out in order to help our patients and help them live a better lives, that's where we can hold agency as providers.
What's interesting to me is, and this is a slippery slope, and as an academic researcher, I fall on the conservative side of this, but within the longevity community, which I'm a big part of, as well as you, the word is used as evidence influenced, not evidence-based, right? And so within that community, it allows them to practice with more creativity, if you will, knowing that we see a trend, but we don't have a one-to-one correlation. And, whether or not people feel comfortable with that, that's part of the agency of being a patient, actually, deciding how you want to be treated. But that's part of what's going on here. There's just no money for women's health right now. So anybody listening, if you want to do something really good for yourself and the health of other women, it's to start petitioning the NIH to fund women's research, frankly.
Which I think would be like maybe very high on their list, since we're 51% of the population. And, I don't know. It's very weird to me that that's not maybe one of the first things that they would think of as very valuable for research.
Well, as a researcher, I can tell you, I'm not letting people off the hook, but in case people are wondering, research is incredibly expensive. I mean, I had, for experiments that I did proving that exercise will stimulate muscle stem cells, satellite cells, one mouse treadmill costs $30,000.
What? One mouse? Just a treadmill?
A treadmill for a mouse with two legs.
Why are their treadmills more than ours?
Exactly. So if you add that up, research is really expensive. So researchers are like, most of them are men, by the way. How am I going to get the biggest bang for my buck? I'm going to do research on one small population, usually 40-year-old white men. And they try to apply that across all people, all genders, no matter what your genetics are. And I'm sorry, we know that doesn't work now that we're in the era of precision medicine, thank God, right? But it's going to take us forever to catch up. So in case you're wondering, people out there, that's why. But I wanted so we talked about heart disease, number one killer of women. Number two has got to be the accumulation of all the metabolic syndrome diseases. So let's talk about estrogen, diabetes, metabolic syndrome, what insulin sensitivity means.
Yes. So again, going back to kind of that mailman type of chemical messenger, is our body really functions. It's like a machine. It's like a car assembly, and everyone relies on everyone to get a part done. And then that next person or that next thing can do what it needs to do. So as we start to age and we start to have fluctuations and decline in hormones, again, this assembly line is like oh, well, homeboy didn't show up today to work. So how are we going to make the next part? And so all these hormones are like, I don't know what to do. Are you going to do the job? And so that's where we start to see this disruption. And insulin and glucose, to me, are kind of like the hallmark of how our bodies are working, how they're able to function, how well they're able to shuttle all the pieces and parts where they need to go. And so insulin, again, is kind of the main thing that's going to take glucose and say, okay, I got you. I'm going to put you where you need to be. And in that aging process, we start to see the utilization of glucose, one, because we lose our muscle mass, two, because our fat cells are like, well, I'm going to sit around a little bit more and get a little bit bigger, and I'm going to try and use this glucose as well. And also because insulin is not going to be as effective. So you have a problem with the main person who's taking in all the information, and also the body parts that are not using the glucose. And so this constant, dysfunction rather of these two then sends out all these bad messages, and everyone's going to respond that way. It's going to increase inflammation. It's going to allow, again, glucose to sit around longer, which is going to increase your risk for heart disease, type 2 diabetes. And that is why, going back to what you and I love, which is longevity and muscle, is that's why muscle is so important, to make sure that we're maintaining and building that so that it can absorb that glucose, because it's the largest utilizer of glucose. So it's such a hard topic to kind of discuss with patients, because it seems so abstract and you don't necessarily see it or feel it. And many times people respond to their bodies when they feel it. And so teaching someone what's going on internally to pay attention to it the best that they can, so that they never get the symptom. And that's most of the conversation that can be the most difficult, but be the most rewarding if you really take it in and saying, I'm going to work on this.
You're right. Unless they feel it, there's no way they can see inside their skin to see adipose and muscle. And although I think what I'm going to do tomorrow in this event that you and I are both in, because I'm an orthopod, I have a way for people to see what you're talking about, and that I'm gonna send you a copy so you can blow it up in your office. It is a picture of a woman's leg that has osteoporosis, sarcopenia, and adiposity, all in one leg.
I want to see that.
I know. I'm going to give everybody a copy. So, because if women can only do what they feel, you can't feel that. Your jeans don't fit well anymore, but you can't see it. When I show women, look at the total width of your leg, look at the 1 inch of bone, you have tiny, tiny little muscle mass, and the rest is fat, they get that, right?
Yeah.
It's visual. It's visual. Fat is a noxious metabolic organ. So it's great that you're talking about a muscle in your book, muscle out on the airwaves, but why do you think muscle is having its day right now?
I think muscle is having a day, and I really give a lot of credit to a lot of my colleagues who are on the exercise physiology PhD side, because that's actually where they focus their study on. And so it was a pivotal time, probably, I would even say 10 years ago, because they were kind of ahead of the curve before we were seeing this in medicine, is this significant change in a women's muscle mass when they started to go through perimenopause. And so for them, they were like, whoa, wait, what? And this is very fascinating in the sense of, if this is happening now with research, what could we get if we started to emphasize more weight resistance training, weight building with women? What does that really mean on the other end of that? And that's really where you started to see the studies of building more muscle mass, what it would mean, and what were the metabolic effects of that as well. And so I think from that, now that we kind of have a really good foundation of this and understanding, again, now that we're like, this estrogen depletion thing is really impacting so much of a woman's life, putting that all together. And now here we are is saying, oh my God, estrogen is really important, but also these are the organs that are going to actually have a significant decrease of sarcopenia. Let's get that back up. And so I'm actually very happy that we're kind of seeing the merge of these sciences together while we're trying to refute and kind of push away the disinformation that was done with the WHI. So it's kind of like this perfect storm And I'm so glad that we're able to utilize the information at once rather than it just being a hormone campaign. And then maybe 5 years from now being like, oh yeah, by the way, it's muscle too. And then later down the line. So I'm glad that they're kind of like building a really good kind of layer cake effect, except we shouldn't eat the cake because it has glucose. But you know what I mean? That layer effect, that we're going to get the best benefit. Because again, in the book, what I really emphasize is it's never just one thing. It's not, as much as I'm a hormone advocate and I love women being on hormones, it's much more than just the hormones. It's what am I doing with my protein and nutrition? What am I doing with my workout? What am I doing with my mindfulness and my cognitive, behavioral therapy and meditation, flexibility, posture? All of those really have to be part of the puzzle.
And so when in our conversation, we've talked about how you help women get past their own gates, how you help them determine whether they're ready for change, to address some of the fears they have about cancer and heart disease and that kind of thing. So once they get ready and you've helped them, you've prescribed a lifestyle program, and they start taking the baby steps and layering it on, how fast are they going to see results?
Yes, I tell them, unfortunately, you are on the marathon journey. We are really going to see these outcomes. I usually never quote them anything less than a year of what we're really looking for outcomes. Because if I set this very kind of short thing that you see like in the fad diet trend is in 14 days, you're going to lose 14 pounds or more. I never, ever prescribe that because I say, I need this to be sustainable. And I want you to still be doing these same habits because we've taken the time to form them when you're 77. And if it's easy for you in 3 months, that is a little concerning because I want in a year that you're still doing it so that this is something that you can repeat over and over again when you're in your 60s, 70s, and 80s, and even in your 90s.
It is so hard to set a goal for, maybe it's just me. I doubt it. Hard to
I don't think you're alone in that one. No.
A goal. It's hard to set a goal for a year and just keep my eye on the year prize. And so I personally break things up.
Mm-hmm.
Find that in the women you serve that you set goals, but are micro goals that you hit?
Yeah, we do micro goals, but that never is the end of it. I want them to say, this is something that's long-term, but here's some micro things we can look for. Yeah, you kind of do like the breadcrumbing a little bit and saying, we can get this and then we're going to move to the next one and the next one. But I ultimately want them to know, I want us to look back in a year and being like, man, look at what I was able to do. And I think because we live in a society that is very next day, 24 hours, it flashes. If it's not there, then we failed. That is not the road that we're entering. And that's why it becomes so hard for people to really turn this corner, is because we live in a society that wants you to complete something by the next day. And so that's why I actually do implement into a lot of the patients that I see is some type of therapy or
behavioral
life coaching. Yeah. We have licensed therapists in our practice. And I think too, the other thing that I see in perimenopause is there's a mind-body disconnect. And so your bodies are going through all these changes. You have this increased anxiety and depression and irritability. And so it's these two things trying to do two separate things. And I'm trying to really merge them all together so that there's an alignment between this very difficult, and I'm not going to, sugarcoat it. This is a difficult transition. But if we can change the perception of what it is and how it can be a beautiful transition, then that's when actually things start to align more, is because you're not fighting something, you're working with it.
God, that's been wonderful. Yes. I'm pausing because exactly, I think we feel so bad initially. We kind of get stuck in this little vortex. But the fact of the matter is, so this is a good time to pivot. Let's pivot and tell me what's good about menopause and beyond from your point of view.
Yeah. If you think about it from a society-wise, a lot of times we are given value as women during our reproductive years, right? And that's when we're important, and that's when we are important to society. And after that, which hallmarks menopause, because you don't have a cycle, you're not ovulating, is that you maybe don't have as much worth, or you're not as visible or useful. And so that's why I champion for this to be actually a time that you can spend on yourself and explore, try new things, spend more time with yourself and what you would like to ideally become and how you think of yourself. And so that actually does become more me time. And so you get to decide how you would like to do that me time. Do I want to sign up for this, club of gloominess and despair? I don't. We have an opportunity to say, do you want to sign up for this, or do you want to sign up for this? And so that gives people agency in pushing away from this narrative of that it's scary and everything is miserable. Is everything pleasant? No. But do we have modalities in where we can change the perception of what's going to happen? Yes. And that's what I really want to always be able to do, is say, here are these options. And here are things that actually have been proven to help. Here are things that you get to try. And if you don't like it, you don't have to do it. But you get to dictate what this journey can look like. And that's why I always say with the book, Generation M, you get to create your own journey. And that can be fun. That can be exciting. That can be exhilarating. But if we don't put that context to it, then we'll continue down the road of thinking that menopause is this dreadful, terrible, horrible stage. And I really don't believe that that's what we have to subscribe to.
I agree with you. I think mindset is critical. I mean, I think to the athletes that I take care of, they have a year-long goal, right? They're wanting to win a championship or a ring or have a 14-0 season if we're talking about my teams. Every week is a grind.
Mm-hmm.
They could have the point of view that this is a horrible thing. It's going to hurt. They're grinding they could lose sight of that. Or they could have the perspective that I am going to build myself into a champion. And I think that's what you're saying. It's the ability to pivot mindset from recognizing that today might suck, but tomorrow may be amazing. Or today is amazing, tomorrow's workout might suck, right?
Yeah. And that's, to me, is like the fundamentals of neuroplasticity, is how do you change the brain to think differently, to wire differently, to accept things and push things away. You get to do that, but you have to be able to jump into that phase of, I can do better, I want better, and I'm going to show myself how to show up in a better space.
Love that. Before we got on, or maybe we were on the Instagram Live we were talking about the fact that I was a geriatric mother. And then you said I was too when you had your sons. And so, at this point, my children, we're a blended family. 5 are totally grown. 1 is 17. But sometimes when I think about why I do this work, it's because I'm not going to lie to my children, my daughters in particular. And I have a question for you about your sons, but I am not going to lie to them and tell them that they can live life equally to their brothers. Because, what does that mean societally? Well, equal pay, equal time, equal career. But for me, it's bigger. I do not want to lie to my daughters-in-law. We have 4 sons, so daughters-in-law.
Yeah.
And lie to them by not fixing this now. So with your own sons, what do you want them to know going into their lifetime relationships, or maybe taking care of you when, it's their time to take care of you?
Yeah, I think what we have done when we think of gender alone, males and females and going through transitions, is to leave it alone, right? Like, so if a female family member, mother, sister, wife, partner is going through something, is to turn the other way, right? To be avoidant to it and just let them go through it on their own. But I really find that support and being in the collective of, I understand and I hear you. I may not be experiencing it, but I am here with you and you are seen and heard. Because I think what has created this structure initially was, again, you're out of the reproductive phase. Thanks for your service and your time. And then women, literally, like, that's how it feels, is that, women would take that messaging and saying, oh, well, no one wants to hear what I have to say, so I'm going to go over here and just like be in this corner by myself and miserable. Imagine even what we're seeing now with the rise of being aware of menopause is that it allows women to stand stronger in their discomfort or to say, yes, me too, I feel that way. What have you done about that? And so this is the type of conversation that if more women could have that freely in their homes, in the presence of a partner or a spouse or whoever, or in the workforce, right? Imagine what that type of community could create. So I think for me, even as a gynecologist, and obviously I talk a lot more about women's issues than maybe most men or women do around their sons, still, you may not understand everything. You may not understand all the biology and physiology behind it. But again, being present and allowing someone to at least express what they're going through, that alone can really change the narrative and the type of conversation and support that they can bring to their partners in the future.
Absolutely. I love that. That's the framework you're setting up, because you tell me if I'm wrong, but I believe, I was going to say, having been around a while and gone through relationships in my life, that I think this work is going to save some marriages. Don't you think?
I actually have the perfect story in the book, and she's actually a friend of mine and is very vocal about this story. As she had surgical menopause, late 30s, had some issues, had a hysterectomy and her ovaries removed, didn't realize that that was going to bring her surgical menopause, which makes me very upset.
Who didn't tell this woman?
Right. So now here we are, fast forward, surgical menopause, and now going straight into more of the irritability and anxiety and depression, knowing what's going on, again, in a marriage. And it got so bad that they got divorced because she was just like, I don't know what's going on. Got on hormone replacement therapy and was like, I feel like a person again and I feel sane and oh my goodness. And a year or two later, got back together with her husband. Isn't that just like such a wonderful story? But it was the miseducation, misinformation, and not being told, and then having to go home to a partner who's like, I don't know what's going on, dissolving a complete marriage because of something that was done and misinformation and not knowing. I mean, that, I don't know. So many marriages and relationships, because even the woman didn't know what was going on. So it's not so much the man didn't even, the woman was like, why do I feel like this? Not relating it to, oh my gosh, I'm going through perimenopause or menopause. And this actually is one of the features and symptoms of menopause.
Right. So, well, I just think this is work worth doing. I love that we're in this same inward and outward facing group trying to change the way people perceive, talk, are treated from midlife and beyond. So as we wrap up, thank you for writing Generation M.
Thank you.
Is there anything in closing that you want my audience to understand about your work, about this time of life? That we covered.
I really think, and I say this over and over again, and it's so true, but Generation M really was the ability for people to see themselves as part of something positive, part of a transition in their life that is going to happen to 100% of women. But we have the ability to be part of a community that has agency, that has the ability to see themselves in a better light, that has the ability to have things that they can do in their everyday life that's going to make their lives better, but also being empowering. And so the community to me was the biggest part of why I wrote the book, is because I wanted to share something that is an easy read, but for all women. This is something that no matter where you are in the journey, that you can find something that is going to speak to your life and is going to be encouraging.
Well, that's wonderful. Well, thank you for taking your time. Thank you for letting me be part of your book launch. And I will see you tomorrow.
I will see you tomorrow. Thank you so much for having me on.
My pleasure. Bye, Dr. Shepard.
Bye-bye.
I'm Dr. Vonda Wright. See you next week.